Hello and welcome to All About Billings. We are a show dedicated to discovering the people who make Billings a great place to work and live. We will interview local business people, entrepreneurs, community leaders, artists, entertainers, and we will learn from them all about their successes, their challenges, and their connection to Billings. I'm your host, Nancy Brook, broker and owner at Billings Best Real Estate. Today it is my pleasure to welcome from Community Medical Services two gentlemen who are going to be talking about therapy for opioid addiction. I want to welcome David Phelps and Ari Greenberg.
Thank you.
Welcome to the show, gentlemen.
Thank you.
Well, we had an interesting conversation before, just kind of talking all about opioid crisis, I guess, in the nation, but it's here in Billings as well. So maybe you could start by just talking about, what you guys are seeing in Billings.
So the basis of our treatment is we provide therapy for people with opioid use disorder. That is people who struggle with a variety of different types of opiates. Predominantly in Billings right now it's fentanyl, but in the past it started with prescription pills, people with a history of heroin addictions, and the progression currently has been to fentanyl, which has been a nationwide issue.
Right. And fentanyl, you're finding it laced into everything. It's even in the methamphetamines and marijuana that you buy off the streets now too.
So I'm going to take like a little side route because this has bugged me for a while. Why do drug dealers put fentanyl into marijuana and other things when people don't know it? It almost seems like they want to kill people.
So fentanyl, heroin, oxycodone, all these opiate products, they work by what's called central nervous system depressant. The key word is depressant. So they affect the brain differently than other drugs such as marijuana, cocaine, methamphetamine. Those are more, well, not marijuana, but methamphetamine and cocaine are stimulants, so they're uppers, and where the opiates are more like a downer, a depressant. Somebody who's dealing drugs recognizes the addiction is much stronger when you give someone opiates, so they want to add and increase that opiate, let's say, addiction with their other drugs that they're selling on the black market. So they'll add it with powder, sprinkle it into the... They don't understand it's a different... They don't care, I should say.
They just want to sell their products.
There's a different mechanism of action. They just know that, hey, this makes them really addicted. Let's add it to the other products. Unfortunately, if you're naive or you've not been exposed to any opiates, and you get exposed to something powerful like fentanyl, you're at increased risk for an overdose because you're so sensitive. Your tolerance is really low, and you're so sensitive when you utilize something like methamphetamine or cocaine.
Right, and that's why people are so sensitive that they could die just from a tiny little bit
of exposure.
But then it's interesting because fentanyl is used by medical providers as well. And I know medical patients who use it for pain and whatever
to this
treatment.
Day, to this day, fentanyl has been, from the 1960s to this day, has been a highly effective pain management, anesthesia for major to minor surgeries, and even dental procedures, and very effective in controlled environments.
Right.
Unfortunately, it's not a controlled environment when you're dealing with illicit fentanyl.
Of course, of course. So let's talk a little bit about, the problem in Billings. You said it's not unique to Billings.
Yeah.
It's happening across the country, and Billings is not immune.
Correct.
And as we were chatting before the show, one of the things that we were talking about is how maybe some of us are a little naive. We don't see what's happening right around us, that there are a lot of people who have addictions. And so what kind of issues are you seeing in our city?
Crime has gone up. When you're taking fentanyl or an opiate, it's short-term effects. It only lasts for a short while, so you've got to replenish that. You've got to replenish it to keep from feeling those withdrawal symptoms. So then the withdrawal symptoms are like the flu times 10. It's miserable. And so people get desperate. And so they're trying to find any way that they can get their next fix. And that's one of the things, because we're a methadone program, and that's one of the things that's nice is that the methadone, once you're on a stable dose, it lasts a full 24 hours. So you don't have to worry about waking up at 5 o'clock in the morning feeling sick. You're on your medication, you come in, you take your dose, you can go on about your day. The medication makes you feel normal so you can function, and then you can focus on other things, whether it's finding a job, finding a place to live, repairing relationships, things like that.
Yeah, right. What do you see, Ari?
Methamphetamine, cocaine, you can overdose on those drugs. It can cause toxicity, cardiac issues, respiratory depression. You can die. But there's a greater risk specifically with fentanyl because it's 100 times stronger than morphine. And so it's far greater, more potent than, let's say, an oxycodone. And when fentanyl was first introduced to, let's say, most of an agent illicitly and into our community, it was through pills that mimic or counterfeit likes of oxycodone. And so people were taking what they thought were oxycodone, but it was really manufactured pills from whether the cartels or anyone with the pill press to put a little bit of fentanyl into a pill-shaped form. And they didn't realize that they were taking a drug that was higher potency than just what they thought was prescribed oxycodone or oxycontin or hydrocodone. So that risk for overdose is significant, and it greatly impacts our community. It affects everybody who's at risk for opiate addiction. And we like to say, unfortunately, there's no prejudice when it comes to opiate addiction. It affects people of low socioeconomic status or people with professional careers. It's a wide range. It doesn't care about race, gender. It affects everybody in the community.
So I know a lot of times people will get hooked on prescription drugs because they've had some kind of situation, maybe a surgery, maybe some kind of pain, and then they can get hooked. What are you seeing in terms of ways people get started with an opioid addiction?
That is one way. It can come from using other drugs and getting exposed illicitly through the dealer. So
Sure.
If you've been using this, why don't you try this? When it comes to prescribed medications, not everyone who takes an opiate becomes addicted. There's usually several more factors involved, whether it's abuse, trauma, maybe organic issues like psychological issues, which contribute to their need to control those problems, can lead to a desire to want more and more of that drug.
Well, and when we were chatting a little bit, David, you had also mentioned that sometimes people just get started and then they don't even realize that they're getting hooked, and so and all of a sudden they're kind of in over their heads.
Correct. We've had a lot of clients who have started on legitimate pain medications, and they like the relief it gives them, and it just kind of continues from there. Next thing you know, they're taking more than what the doctor says to take, then they're running out early, and it's just a ball cycles.
Well, and I suppose it's hard too, because sometimes, when I've ever had to take an opioid, it's very controlled. Like they give me maybe 7 pills, and so and they're very cautious about prescribing more.
Right. Yeah, the greater length of time of exposure increases the risk for physical withdrawals. Once someone builds up a tolerance and there's a need for more and more of an opiate of any sort, there's also a thing when your body doesn't have the opiate on board. You get that, like Dave described, the flu-like symptoms. And it's a variety. It's hot and cold flashes, night sweats, problems with your GI system. And the analogy I like to put out is that when I get flu-like symptoms, or I eat a bad taco, or have issues with allergies, which runny nose, sneezing, restless legs, anything that I get associated with those symptoms, without addiction, I know whether it's a week or even 2 weeks, those symptoms will subside on their own without interfering. But with people with opioid addiction, there's this recognition that, oh, if I take another one, those symptoms go away. Then if I take another and the symptoms return, if I take another one and the symptoms go away. And this process repeats itself. And by doing so, there's a rewiring of the brain in which you reinforce that behavior. And your body, your mind physically changes. We call it neural pathway development, in which it becomes excitable to these symptoms and the behavior associated with it. So it repeats its process over and over. In fact, that is how we describe addiction, is the repetitive behavioral or process in which you know it's negative, but you do it anyways.
Well, and with that, I'm sure there's some positive because you don't want to feel those withdrawal symptoms. And so it kind of reinforces it, even though maybe you just are like, man, this has control over me. And I don't like it, but what am I going to do?
There can be recognition that it has control, but still, it doesn't matter. I know I can still fix this by getting another opiate. And these symptoms are pretty significant. And so by getting another opiate of any sort, unfortunately, in our current market with the expansion of fentanyl into our community, the tolerance, someone who gets exposed to it builds and builds and builds, so nothing lower than fentanyl can fix their issue. Now they become hyper-focused on getting specifically fentanyl, and it comes in pill form or in powder form. And some people utilize the pills to get high, and that's typically early on in exposure. There's a desire to get high, a euphoric response, but with repeated exposure, that euphoria goes away.
So it's just like being normal then, in a way, after a while.
Not normal, the euphoria goes away, but the withdrawal symptoms become intense, and those don't go away. With lack of any opiates in the system, they just need to fix their problems. And like as Dave says, what used to last 6 to 8 hours may last only 4 to 6 or even less. And they need more and more and higher amounts. And that's what we call tolerance builds up.
Right.
But you touched on something when you talked about the recognition, recognizing that they were powerless to the medication and feeling like that. That's actually one of the first steps that we see for people deciding to come in and see us.
So they know it's a little out of control, but they don't know what to do.
We're completely a voluntary program. Nobody there's court ordered. They come in because they want help. So that's nice. And when they come into the program, even if they show up at 5 minutes before we close, we're going to get seen. We're going to get them taken care of that day.
Wow. And so when people, I guess, get started, a lot of times, so it could be like a medical situation, and then it gets a little out of control, or they're just maybe having fun, getting high or whatever, experimental like a lot of people are. And then all of a sudden it gets them. And then how do they recognize that they need to do something, and what prompts somebody, or if you are a family member or a loved one and you see this happening, what can you do?
Family would be one of the ways people recognize they have a problem. Family confronting them about it. Circumstances in their life changing, losing their job, losing a place to live, losing their kids, different things like that can help them recognize there's a problem as well. If you're a family member, the bottom line is you got to show them that you still care. That's one of the things that, they have to know that I love you, but you need help. That kind of a thing. We've had people who have, we've had people come in and said, my mom says that I need to come in, or I'm getting kicked out of the basement, or whatever, so. And sometimes that works. Sometimes they've got to just recognize that they have an issue for themselves.
And how do they recognize they have an issue? What is it that prompts it? Because
whatever significantly impacts their life. Loss of bank account, they lose money because they're spending so much on the streets. Friends, family, personal relationships with spouses and their own children, or
legal issues,
personal self-esteem, feeling down in the dumps and not recovering, anything to make them feel better. And there's so much variety. You can't pinpoint and create a template and say everyone fits in this one box. It's incredibly varied. Everyone takes a little bit out of that box and makes it a part of their own personality, but whatever it is, it alters them to a point where it can have a significant impact on their personal hygiene and their own health. And they'll look upon as that, whether it's pain or maybe their dental hygiine or their personal self-worth, and they're not, taking care of themselves, living what they were once living in a home, now they're unhoused. All of these play a role in what changes someone saying, I need help.
You could have 50 different people. They could all have started for 50 different reasons, and you could all, and 50 different reasons why they've decided to come in and get help.
Well, and I guess there's probably different levels too, right? Some people maybe, let's just say, catch it early, like maybe they got a warning at work, or they had a DUI, something like that, and then they're like, oh man, I need to change this. And then other people maybe have to lose almost everything before they change
rock
anything.
bottom.
Yeah. So I suppose it does just depend on the person and what they're losing in their lives.
Yeah, and what they can perceive as a problem.
Right. And so how does it work when they come and see you at the clinic?
They show up. Like I said, we'll do an intake we'll get them in right away. They'll see the medical provider. They'll fill out paperwork and see a case manager. We'll do a UA with them. They'll see the medical provider. They'll see a counselor. Counselor will do an intake. Counselor will set up treatment plan goals with them, things that they've identified that they need help with, whether it's finding a job, repairing relationships, just trying to stay out of jail, just whatever goals that they need to work on that will help improve their life. And then they take their medication and come back in the next day.
We know this patient population are at great risk for overdose and possible death.
Sure.
So at intake, there's no scheduling. They come in, we take them in immediately, and we try to get them treated immediately. And that includes getting them on a medication immediately.
Taking that first step is hard, so we don't want to turn them away.
Yeah.
Well, and like you said, it's almost like, somebody who's a diabetic needs their medicine.
Right.
I mean, and so how does it work, the methadone?
So there's several medications that we utilize. Methadone and buprenorphine products are the primary drugs. They both work, to get technical, they both work on the opiate receptor. Basically, whether it's heroin, fentanyl, or oxycodone, occupies a receptor in your body called an opiate receptor. And when it's not there, you get these withdrawals. By adding methadone, which fits perfectly into that receptor, or giving buprenorphine, which almost fits perfectly into that receptor, you're controlling those withdrawal symptoms. But both of these medications, being synthesized, man-made, they last, when at the right dose, for 24 to 36 hours. So as opposed to the illicit drugs, which can be short-lived, 4 to 6 hours, and then going searching out for more drug to cover their symptoms, we're providing treatment where they know for 24 hours they're going to get covered by this medication. And so that's the first thing we try to get them on. And depending on the history, we make decisions together with the patient on what's the best treatment option. Methadone's been around since it's actually been around since the 1930s. But first found to be a benefit in the 1960s for treating people with opioid use disorder. Because in the 1930s, the Germans were embargoed prior to World War II, and they weren't allowed to have a morphine access, so they synthesized methadone for pain management. But it wasn't really good for pain management. It was difficult. It wasn't as good as they thought it would be. So it was not widely used until the 1960s. There was an aha moment with a group of very smart people in which they realized they could treat people with their addiction, heroin addiction back then, with methadone. And it's widely studied and understood and well accepted around the world. And then I think it was in the late 80s, buprenorphine was discovered. We also know as Suboxone, and in 2000 it was approved for treatment. And it does the same thing, fits into the receptor, controlling withdrawal symptoms over 24 hours. Both great medications to utilize to control withdrawal symptoms so people can get their lives back in order, get back on their feet.
It's interesting, because I was a counselor before I was a manager, and one of the things that almost every client has recognized, once they're on a stable dose, the anxiety seems to go away. Waking up thinking, oh my God, I've got to go find something.
Right.
They're waking up and realizing, wait a minute, I feel okay. I feel normal. I can, and that just motivates them to encourages them to continue.
So is the medication a lifelong treatment, or they do it for a period of time?
So the goal is not to be on the medication indefinitely. It's to stay, well, first of all, number one, when the medication occupies these receptors, it actually prevents in case they continue to use another opiate, so specifically fentanyl, and keeps them safe and reducing their risk for overdose. So with buprenorphine on board or methadone on board, if they were, I like to say, like, once you get started with this treatment, you can walk up to your dealer, hand them money, but don't ask for product, because that's really what's going to happen. You're not going to feel a euphoric high, and the risk for overdose are dramatically reduced. It's still possible if they choose to try to override the drug that we give, but it's highly unlikely. So, and generally by this time when the patients are coming in for treatment, they're motivated not to want to go out, but they still might use because habits are hard to break, around old friends, colleagues.
Yeah, right.
Triggers, emotional triggers, what I call memory-like triggers, in which they smell, hear, taste, feel, triggers memories associated with their drug use, and they might get compelled to use, but they do so and realize nothing happens.
So what's the point? I mean, really.
And that is why.
It's like, this isn't doing anything for me.
And that is, well, number one, we're trying to keep patients alive. That's
of course.
Goal number one.
Of course.
And that's why we give the medication.
Harm reduction, that's kind of our model.
Sure.
Number two, stabilization. And that's where we start working towards what you just described, like, what's the point? That physical or psychological compulsion is still there, but now they're starting to learn, like, it's not necessary. Now, the craving or the trigger will always be there the rest of their lives. But stage 3 is learning how to manage that trigger or craving. So when you're off methadone, you're off buprenorphine, you've got the mental or psychological skills to say, I recognize this trigger, I recognize this craving, I know what to do in this situation without resorting to opiates of you fill in the blank.
Well, like you said, sometimes you use it for one reason, and then it kind of gets a life of its own and becomes a habit, and and you have friends surrounding this, and it could just really escalate. So that's why if you don't get anything from it, you're going to lose interest in spending all your money on nothing.
Triggers and cravings. Sorry, Dave.
Go ahead.
Triggers and cravings are normal.
Right.
You have them. Dave has them.
Sure. I want some carrot cake, but I can control myself.
I walk down an alleyway. I smell, carrot cake. I smell smoke, and I'm like, I want barbecue. But a barbecue is not going to wipe out my bank account, destroy my social relationships.
No, not cause you.
Because I don't have withdrawal or physical compulsion to have it endlessly.
Right.
Whereas with the physical withdrawal symptoms and whatever psychological issues associated with it, there's this compulsion to use it in spite of the negative consequences.
Sure.
That's one of the things that they work on in counseling with their counselors, learning to recognize and how to address those triggers, those cravings, find other options, alternatives.
Well, and I'd love to ask you both, what has made you want to pursue this as a career? I mean, it's definitely, something that I suppose has a lot of emotions on your part to get involved, and
it can be very
to help
emotional
people.
at times,
Yes.
for sure. But it's just helping people. I worked at a place in Arizona with adolescents, a rehab center with adolescents in Arizona, and then moved up here. I've just always done a lot of that. I worked out at the Boys Ranch, different things like that.
So you just enjoy making a difference like that. Yeah. How about you?
I've been a PA since 2000, so I've always been in the medical field, so wanting to help has always been part of that.
Yeah.
It was introduced to me when I was working at another clinic by a medical director who used to work at this facility, and he mentored me into coming, and I just fell in love with it because technically it's very demanding, you know, it's very interesting, and also the impact is dramatic when someone who you see is struggling so significantly, and you can ease some of specifically like I always tell patients, controlling with physical withdrawal symptoms, that's actually kind of technically simple on my part, but I have a lot of variables to look out for, and that's my job to do so. But the relief associated with the physical symptoms can be obtainable really quickly early on in the program, within a couple of days to weeks, depending on which medication we utilize. The psychological symptoms or the skills to develop can take anywhere between 2 to 3 years on average, because it's ingrained, this behavior, and there's a lot of factors involved. And at the same time, let's face it, a lot of people have lost a lot financially, personal self-worth, socially, and they're rebuilding that. It takes time to rebuild,
of course,
that base again.
And probably their self-confidence as well.
Absolutely.
I mean, if they've been down a bad path and people are
and
criticizing them, and
I was about to say criticizing. It's not just personal self-worth; it's societal self-worth. You know, worthiness. That's, we call it stigma, basically.
Right.
And that stigma plays a huge role. For those who don't understand, these individuals are trying to regain themselves and include themselves back into society. And this is an opportunity for them to do so. To shut that door is incomprehensible to me. And that's why it's part of the reason that I continue to do the work I do, because I'm watching patients grow, and some patients remain stable, and that's all they want. Quite often, patients and clients will waver back and forth to treatment, disappear, and that's okay. Because I know when they come back, they're still here, they're still alive, and I'm able to treat them.
Well, and let's talk about, how do people contact you, get in touch if they have an issue with opioids, or if they have a family member? What's the best way to get in touch?
Just to call the clinic or just show up.
Okay.
We're located at 2040 Rosebud. We're in Suite 7 and 8. They can just show up. If they're wanting help, just show up, and we'll get them taken care of.
And your website, we talked about that.
communitymedicalservices.org.
Okay.
It's a national company. There's 80 clinics nationwide.
Wow.
When I started, there was 3 in Montana and 4 in Arizona, so it's really grown.
Well, it's a wonderful service that you both are doing, and all of your staff, to really make a difference in people's lives and keep them alive. Not just help them live a better life. You're actually starting by, let's keep you alive.
That's number one.
We give them Narcan when they come in as well, to take with them in case of an overdose, if they're with somebody who has an overdose. We had a situation a few years ago where one of our clients pulled into the parking lot and ran in that somebody in his car had overdosed, and he didn't know what to do. And our nurses actually went out and saved that person's life.
Wow. Well, you guys are really dedicated to helping people, and I applaud you. It's, you know, it's, like I said, it's not an issue that I really think about, notice, but it's all around. And that's my lesson, is just because I don't notice it doesn't mean it's not right in front of me.
And whether it's cocaine, methamphetamine, or opiates in general, they're still people. And they're individuals trying to survive and understand what's going on with themselves, and they need that ability to grow.
Yes.
I'd like to give a shout out to our staff, because that's one of the things our clients have always told us, is that they come in and they don't feel judged. They get judged everywhere else, but they come in and they don't feel judged.
Absolutely. Well, gentlemen, it's been wonderful having you here today. Thank you so
Thank
much
you so
for
much.
educating us all on what you do, and I guess how we can help our fellow humans who are going through this. And everybody, thank you so much for joining us, and we hope to see you next time on All About Billings.